So, Dr. Liggett, what does Black Maternal Health Week mean to you?
Wow, I feel like it means so many things. I think just reflecting on why it was that I became a doctor in the first place. I remember just thinking about my mom who worked tirelessly in a nursing home caring for individuals. And that was really kind of the first model of caregiving that I saw in my life as a young child. And I knew that I wanted to be a doctor just like her, although she wasn't a doctor at the time. And so that always was very deeply imprinted on my mind, kind of what healthcare looked like, what caregiving looked like, and what the possibilities for healthcare could be. But I think, as a young person going through my 20s and going through my early 30s, I was generally pretty healthy and didn't have very many health problems. And also being a doctor myself, doctors don't really go to the doctor until I got pregnant, which, obviously forced me to interact with the healthcare system as a patient, which I had really never done before on a regular, consistent basis. Um, and I was just quite surprised that the experience is actually very jarring. In some cases, traumatic. In some cases, felt like I wasn't listened to. My opinions weren't valued. Even as a doctor myself, the autonomy around decision making, it wasn't really a shared process in many cases. And so I feel like there was just a lot of room for improvement. So, in terms of what Black Maternal Health Week means to me, I would say it's both a personal and a professional passion to improve the experiences in healthcare for Black women, really for all women. Although you did cite the statistic that Black women are 3 to 4 times more likely to die during pregnancy related causes, we've really seen the largest increase in maternal mortality among white women. So it's very important for us to understand that Black Maternal Health Week is, of course, centering Black women, Black stories, and Black families in finding solutions for this particular crisis, but that really a rising tide lifts all boats. When we improve healthcare and we target specific populations, and it really forces us to examine our systems and examine how it is that we render care to everyone. So it's an opportunity for reflection. It's a week of learning. It's a week of sharing. It's a week of community. And it's, of course, an opportunity for all of us to share our stories with one another so that we can raise awareness around this issue of maternal mortality in our country.
According to the Voices for Birth Justice organization, birth justice is a movement that believes when birthing people recognize their innate power to make the best health decisions for themselves and their families during all stages of pregnancy, birth, and post-birth period. That power will have a transformational impact on their family and community. So, what should people who aren't familiar with birth justice and maternal health understand about the necessity and importance of centering Black and Brown moms in healthcare experiences?
Yeah, I think it's just critically important that, as Dr. Satchel mentioned, that, there's a diversity of stories and experiences that take place when they interact with healthcare systems, whether it be for prenatal care or birthing or even reproductive health. And I think as our country becomes more and more diverse, it's extremely important that our healthcare systems can really keep pace with the need and the demand for a healthcare system that's really responsive to their needs. And in many cases, their needs not only encompass their, biochemical needs or their needs in terms of their body and their health, but also their social and emotional well-being. Also looking at the environment in which they live, grow, age, work, all of these things that I think are not necessarily centered when we see patients on a daily basis, but in fact have the most profound impact on their health. So I feel like it's an opportunity for us to really reevaluate how our systems assess people, what factors they consider when they look at the state of health that person is in, and also the factors that influence their health. I think it's critically important to center Black stories in particular um, because Black women are the group of women and birthing people who experience the highest statistics of mortality and, of course, morbidity. Um, and those experiences are often rooted in bias, rooted in medical racism, and it's an opportunity for us to really talk about that. What is happening in our systems? And I think for the most part, the last point I'll make about it is the narratives in the media, the larger media, have really centered around doctors being the problem. But I think we as doctors are in a unique position to really look very carefully and critically at our systems, really start to break them down, really start to look very closely at where the systemic inequities are and how we can fix them. Because I'm a true believer that people will perform in a manner that the system dictates for them, and that includes doctors, right? And bias is a natural part of human behavior, but stereotypes, incorrect perceptions, racist or patriarchal attitudes towards individuals are aspects of bias that can be very dangerous and perpetuate harm, right? So I think when we speak about Black Maternal Health Week and the importance of centering the Black experience, we have to understand that there are aspects of the Black experience as Black women interact with healthcare that are unique to them, that need to be addressed and that need to be spoken about, right? And that could be really applied to every population, right? So I think that's why it's critically important.
Dr. Liggett, how have you seen this in your work, and how has it manifested?
Yeah, I think in terms of when we talk about compounding forms of marginalization, we tend to think of what that means in terms of healthcare, but not thinking that in many cases our patients are also navigating other systems where they have similar experiences, right? So when they have to navigate healthcare, then it's almost as if there's this, as some of the other panelists had mentioned, this fear, where people kind of come in with a lot of, what would be perceived as unfounded fears around healthcare, around the birthing experience. And much of that has to do with the experiences that they've had, not only in healthcare, but also in other systems that they've navigated, including educational systems, including for some individuals, family systems, criminal justice systems. So these systems, in terms of how they kind of perceive individuals or perceive difference is often very similar, right? Where there's winners and there are losers. How I've seen this in my work, I mean, literally just last night, I was reading a letter that someone that I don't even know personally wrote to me because she knows that I do this work. And then I speak out on behalf of all birthing people so that we can have birth equity and, really center reproductive justice in the work that we do with birthing people around reproductive health. And she wrote me this letter about the experience that she had at Mount Sinai, where her physician was actually Black, and just made the most abhorrent assumptions about her because she was Jamaican. She would have no problems having children because they have so many kids. Because she's a Black woman, of course she's bound to have fibroids, but not really explaining to her why that might be. And this was all happening while the patient was like undressed preceding an exam. So you can imagine how vulnerable and how vulnerable she felt in that moment, and how dehumanized to kind of really have someone who really she felt was more culturally concordant with her also kind of perpetuating these ideals. And I really just want to say that sometimes when we tend to think about who's the bad guy, it literally can be any one of us. As I mentioned before, regardless of where we come from, our backgrounds, we are all essentially indoctrinated into a culture of medicine that with how we learn to assess individuals, the information that we use to make assessments about people in terms of what they need, how we understand their illness, and in some cases not taking into consideration their stories, their experiences, or their values, is a means of perpetuating harm, and anyone can do that. I think doing this work has really forced me to reevaluate even some harms that I have myself perpetuated as a doctor, and trying to unlearn some of these behaviors that I learned in medical school and residency, inadvertent to me, really through an apprenticeship of watching other senior doctors treat patients in a way that was unethical as well, right? But as a student, this behavior is modeled for me. So I think for me, it's really kind of shown up in that manner where patients continue to experience adverse outcomes, have poor experiences in healthcare. That often mirrors the experiences they have in other systems that also marginalize them. And that myself as a doctor, definitely had a role to play in that when I start to reflect on my experiences and my training.
Dr. Liggett, what do you think? What are the top 3 items you would recommend or suggest to improve maternal health care?
Yes, I would definitely say that training is a huge one. I think specifically implicit bias training for everyone, not just for doctors, for everyone who works in healthcare, even if they interact with patients or not, because we have to remember that individuals make up teams and teams make up systems, and we are part of a system. And so everyone really needs to kind of understand what is implicit bias, what is my bias, what are my triggers, and start to explore how their personal lens, their experiences, their upbringing, their family, how all of these things contribute to their worldview. Because once you really start to dissect your own bias, your own modes of thinking, then you can start to interrupt the cycles as you potentially falsely assess patients. I would say the second thing would be reevaluating our systems and where in our systems we can make them more efficient, we can standardize care, and also where we can offer alternative birth choices. We know that midwives are an integral part of the birthing experience and the birthing stories for many individuals, and they can be an integral part of also finding solutions to this maternal health crisis. Right now, we're in a situation where the United States has the lowest number per capita of maternal health providers of all developed nations. And that problem is only worsening. And we know that training the next generation of providers, including midwives, is going to be critical to kind of meeting that demand. So I think, us sharing stories, really highlighting even for individuals who birthed in alternative settings like at home safely or have birthed in birthing centers, those can also be options for people. And then I think the third thing is for us to really value community health workers in our system. That includes doulas, that includes other birth supports, whether they're pregnancy doulas, postpartum doulas, lactation consultants. These are all individuals that also have a role to play in mitigating morbidity and mortality among everyone. But unfortunately, in the case of doulas, which I had a doula during both of my births, and even as a physician, feeling like I needed assistance to help advocate for my needs and ensure that that I was centered, not my health problems or medical problems, but that me as a person was centered in my experience. And studies have really shown that doulas can reduce morbidity and mortality in patients, that having these extra supports are critical. So I think, for our systems to start to value that, to really see that, and more importantly, to pay for that, right? Like these things shouldn't be a luxury for individuals who can pay cash for a doula, but really it should be for everyone, an option for everyone who desires it. So those are some of the things I think might be good.
I can unmute and ask them. Thank you.
No problem.
First of all, thank you, ladies. I was talking with Samantha a few days ago on one of our other committees, and talking about how important I personally feel this topic is. Like I can't say recently, I feel like it's recent, but 3 years ago, and how not only having, like, I gave birth, I was living in Vermont at the time, so I wanted some kind of representation. Finding someone who looks like me would have made me feel more comfortable. But in that situation, there wasn't, and I knew I wanted a midwife and I wanted a doula, not because of being afraid of going to a doctor. I just felt like that was more comfortable. I wanted someone that was actually going to listen to what I had to say, listen to what I feel, and would kind of uh, advocate for me as well, with what my needs and my wants were. And I was very fortunate enough that where I gave birth and the midwives I had, I got to see everyone there who was at that hospital. I got to pick the one that energy matched mine the most, who I felt would be a good fit for me. But from the experiences of like, I have a sister who had a baby the same time I did, and she's having another one. She's going to have it here at Phelps. I think I introduced her to Eve. She has a midwife. She's looking for a doula now too. She had such a traumatic first experience when she had her first baby, and to now see like the 180 from the experience that she's having now, and saying how, you know, now she's going the midwife way for her, but she didn't feel like they were listening before, that they were listening to what she wanted, how she didn't really want to have a C-section. I'm for whatever is going to save mommy and save baby. That is the route that I feel like we should always go. But how she felt like some of the things were pushed upon her instead of actually listening to her and letting her decide what she wanted. And with the amount of Black and brown deaths that you see in maternity, it's always in the back of your mind, because it's like you think something is going on. I think education is important, and having all the resources. I know that even with mine and having such a good experience, they kind of were shocked when they realized I wanted to breastfeed and I was asking those questions. They were pushing formula on me. And I was just like, well, all of my other friends don't get pushed formula. Here's breastfeeding. Do you want a lactation consultant? I had to ask for those things. They weren't provided for me. And then when they realized that this is what I wanted, then it was just like, oh, okay. Like, I didn't know that my insurance would cover a pump. So these were like things that I had to find out from somebody else that had a baby that was just told all this information. So there is some kind of disparity on what information or resources are openly provided for some and for others, which I think need to change. But overall, I do see the difference. It sucks that it's taken so long for it to get here and that it's getting better, but the difference in births between someone of color and someone not, and what resources they're provided, or just what services or what information they're giving, based on other people. But that's all. Thank you, ladies. This has been very informative, and I'm happy that we did this.
Thank you.
Thank you.
Thank you so much for your comment. I just wanted to just follow up by saying, yeah, in terms of experiences, they're actually more widespread than we think they are. You know, it really wasn't, even though a lot of patients share stories with me, it really wasn't until I had my own like very traumatic first birth as a patient and realizing how disarming and disempowering being a patient in the healthcare system as a birthing person, Black birthing person, could be. But then when I started to ask my family members and my friends, and it's like, everybody has a story. So clearly this isn't like a single actor who's perpetuating these harms. It's an entire system of individuals that are, the way that we treat and assess patients is flawed in some respects. So I think it's just important for us to look at that. Absolutely. And I'm glad you had a good experience.
Yes. And she's gonna
Yes,
have,
I feel like
your friend is gonna have a
fortunate.
better one when she comes here.
She is looking forward to it. So when you see me, she's due in the end of June. When you see me bringing all these snacks and stuff to your floor, it's because my sister's there and she gets spoiled because her sister's a chef here.
Okay.
Robbins, I see your hand is raised.
Yeah, hi, thanks. Thanks, panelists. Your experiences are so powerful, and I appreciate you sharing. I had a question. As you may have seen, medicine's finally doing some self-examination about how we use race in decisions about patient care. And, you know, nephrology groups have gotten together and recently changed the formula for the GFR, taking race out of the equation, which was a really positive move. I was wondering, you know, we're talking about Black maternal care. Are there any clinical things that you think are relevant to maternal care that still have some stigma of racism attached that we as clinicians can better analyze?
I think the one thing that comes to mind in terms of feedback that I've gotten from patients is just how we approach trying to recommend contraception, which in many communities of color has a very long colored history in terms of contraceptive coercion from healthcare systems. And also issues of unnecessary hysterectomies, pushing IUDs, pushing pills, and pushing adoptions. So I think for us as doctors, I think it's critically important that we just kind of keep that in mind, how we speak to people about what we're recommending around reproductive health and how we really do engage in shared decision making every single time and really offering the choices and offering information. Um, Sometimes, as one of the newest faculty members in family medicine, sometimes I have to remind the residents that if patients don't want contraception, it's okay. If and also if they don't want to be pregnant in the next year, those things are not mutually exclusive, right? Like there's the fertility awareness method, there's condoms, there are other things that people can do to avoid getting pregnant without necessarily using hormonal methods of contraception, right? But often patients may feel as if we're trying to coerce them into controlling their reproduction, which of course has a very long and sordid history in this country, particularly as you're speaking about Black women who, even going back centuries in this country, were really brought to this country for the sole purpose of reproduction and work. So with that, and those oral histories exist and they continue generation after generation. So it's just important to kind of honor those stories and honor those requests and really for us to do our due diligence to ensure that we're offering options and engaging in shared decision making with patients, not coercing them. So I would say that's one thing that kind of comes to mind immediately.
I have two hand raised, one from Dr. Rye.
Yeah, hi everybody. So first of all, I just want to say thank you for this absolutely amazing session. It's just incredible to listen to all of you and to be part of this. Robin, when you asked your question, a variety of things started going off in my brain as obviously I have my eye towards training, and Dr. Liggett, I so appreciate that comment about family planning and contraception, and I think that I remember several years ago when I tried to get that one key question put into the dialogue of family planning, and in researching that question, the thing that really popped into my head that I hope to teach the residents is central to this is what is most important to the patient, right? To the person in front of you. And so that question of, would you like to be pregnant in the next year, should always be followed by, and what's important to you as we have this conversation. And the next question is not, okay, let me tell you how not to be pregnant if you don't want to be, or let me tell you how to be pregnant if you want to be, but what's most important to you. And in all of family planning conversations, if we don't ask that question first, we're unlikely to help the patient reach their goal, right? So maybe we need to add that to the template too. The other thing, Robbins, as I reflect on the nephrologists and the GFR and how, in my mind, that body of research and that new way of thinking about things, or that new way of looking at decisions that we made decades ago, should really inform all of us as we make any of our recommendations, that we're doing this based on what we believe is true and is correct. But that GFR and where that came from and why we decided to have a different number if your skin was darker, that should really make all of us think, right? And so I have a feeling many more changes are coming down the line. And, when we recommend a statin for people, whatever it is, that we should always have an eye on, this is what I think is right, but let me look at that data. Let me interpret those studies. Let me have a different lens as I'm reading medical literature. And I think if we all do that, we might come to conclusions that ultimately serve our patients better. So let's see what the future brings, but let's analyze our data in a more holistic way. Thanks.
Thank you, Dr.
Thank you so much, Sam,
Thank
for
you.
your comment. I really appreciate that. I just also wanted to add one other thing just about race and kind of how we conceptualize that in medicine. So really with the advent of the Human Genome Project, which was this like massive project undertaking to basically map the entire human genome, which was like amazing. They found that really there's only 0.01% genetic difference between us as human beings, which effectively means that race is completely obsolete and socially constructed, right? So when we start to, in medicine, apply this to our assessments of patients, something that's sociopolitically constructed that really draws from this history in our country of classifying people based on race, that's flawed, and assigning value to them as a result. We really do have to kind of reevaluate how it is that we think about these things, especially as we're reading, interpreting data, and also especially as we model behavior for the next generation of medical trainees, right? So I just wanted to add that. Thank you for your comment, Sam.
Thank you, Dr. Liggett and Dr. Rai. We have 1 minute left, and I know I see Dr. Sparita has her hand raised. I want to give her a quick opportunity to ask her question.
Great. Thank you very much for this panel. It was really, really excellent. This is an issue very near and dear to my heart, maternal mortality, obviously. One thing that we haven't talked about was postpartum depression and how it's handled. I've been working in health disparities for a while, just in the academic level, and I had a Black resident who came to me and felt that, it was when I was working in another facility, we were treating or making assumptions that Black women would not be amenable either to medications or to counseling because of tradition, and that's what a lot of people had said. So we actually did do a small study, in our clinic, getting attitudes of the patients and how they would adapt to being referred to a psychiatrist, psychologist, as well as their openness to medications. And what we found really was that Black women also would like to be referred to a psychologist for postpartum depression or anxiety, and they'd also be open to medication, and their families were open to it. And there was no difference with Black women and with white women, and we had a smaller Hispanic community where I was working. The other thing was that what we found was we were referring Black women less to psychologists. We were starting them less on medications. And, I thought it was just very eye-opening because it disproved, what everyone thought, that traditionally people didn't want to go to a psychologist or a psychiatrist or was open to medication, and then validated that we were doing the opposite of what was needed. So I think it's just really important not to make these preconceived ideas. People are people, and make sure that you're not putting your own implicit biases on these kinds of things, because postpartum depression can be very debilitating, and not referring people appropriately or treating them appropriately it can be very devastating to the family. The other thing that I've learned is if you have a patient who's high risk, I had a patient who had preeclampsia in a prior pregnancy, and she was Black. I told her, if you get these symptoms, you have to go to the nearest hospital. You have to ask for magnesium. And she did. And, it made a difference in her care. Instead of having a prolonged hospitalization, she went to the hospital closest to her. She told them what I said. They called me. I validated what they said. And, she got the magnesium. Her blood pressures at the time were only borderline, and they did go up in the hospitalization. She just was so more well informed with this pregnancy. And I did tell her, you're at higher risk because you're Black. And I think we have to be not uncomfortable talking about that you might be at little higher risk, or make sure we're counseling people the same, because I think it's very complicated. Are they higher risk? Are they not being counseled appropriately? I'm not sure. And I think the things that we have to just be, make sure that we're giving the same advice to everybody. Anyway, and thank you again. This is excellent, excellent panel.
Thank you.
Thank you so much, Dr.
Thank you
Sparita.
so much.
Thank you.
I also just wanted to make a quick comment around that, also just about using race in our clinical assessments, and oftentimes we use it can be used as a proxy for something else, like other social determinants of health. And I think it's important that we as healthcare practitioners be very clear about what we mean, why people are high risk. Are you high risk because you're Black, purely because you're Black? Are you high risk because of the neighborhood that you live in? Are you high risk because you don't have access to food? Are you high risk because of your stress level? Are you high risk because you work in a job that is super stressful for you, or that you are the sole provider of your family? Like, what do we mean by high risk when we say that someone's high risk because they're Black? So that's always also something we have to keep in the back of our minds as we use race in our clinical decision making and assessments.
Thank you, Dr. Liggett. Well, this was a wonderful discussion. I am so grateful to all of our panelists for joining and shedding light is not the right word, but shedding your expertise and your knowledge on this topic. And I hope that we can have more of these discussions.